Greetings from Indian Journal of Anaesthesia. I, Dr. Kiran Mahendru, will briefly present an article published in the July issue of IJA. It is a systematic review and meta-analysis on the comparison of the classical approach and costoclavicular approach of ultrasound-guided infraclavicular block. The infraclavicular brachial plexus block is given at the level of cords distal to the clavicle. It provides analgesia and anesthesia of the upper limb from the mid-humerus to the fingertips. It negates the adverse effects associated with the interscalene, supraclavicular, and axillary approach, which includes phrenic nerve palsy, Horner syndrome, pneumothorax, and sparing of the musculocutaneous nerve. The classical approach, also known as the paracoracoid or the lateral sagittal approach, involves the visualization of the plexus in the parasagittal orientation, caudal to the clavicle, and medial to the coracoid process. The cords appear as hyperechoic, horseshoe-shaped fashion placed around the axillary artery with lateral cord capillate, posterior cord in the posterior direction, and the medial cord in the caudal direction. The block needle moves in the parasagittal plane forwarded posterior to the artery, and the LA is deposited between the 3 o'clock and the 11 o'clock position. In the costoclavicular approach, the ultrasound probe is placed parallel to the clavicle. The advantage is that the three cords are present as a cluster lateral to the artery rather than as a separate placement seen in the classical approach. This might lead to faster onset due to relatively more uniform and predictable spread of local anesthetic in the costoclavicular approach. Therefore, this systematic review and meta-analysis aims to determine if the costoclavicular approach allows faster onset and better analgesia, making it superior to the classical approach in terms of efficacy and safety. The article is reported as per the preferred reporting items for systematic review and meta-analysis. The trial is registered with the Prospero, and it is a systematic review and meta-analysis with RCTs comparing the classical and the costoclavicular approach for the infraclavicular brachial plexus block. Studies which included children comparing infraclavicular brachial plexus block to other blocks, or where blocks were administered via landmark guided technique or using a nerve stimulator without ultrasound were excluded. The population was the patient receiving infraclavicular block in a setting of upper limb surgery, with the intervention group was the costoclavicular approach and the comparison group was the classical approach. The RCTs with adults that compared ultrasound-guided costoclavicular and classical approaches with any volume of local anesthetic for upper limb surgery with or without intraoperative sedation but without general anesthesia were eligible for the meta-analysis. The search strategy included M-based Medline, Cochrane Central Register of Controlled Trials, the WHO, International Clinical Trials Registry Platform, Scopus, and clinicaltrials.gov from inception to March 2023. The keywords included were infraclavicular block, costoclavicular block, paracoracoid approach, lateral sagittal approach, ultrasound, and upper limb. Risk of bias assessment was done using Cochrane Collaboration Risk of Bias tool. Continuous data was reported by calculating the mean differences. Dichotomous outcomes were reported as risk ratios and 95% confidence interval were calculated from a fixed or random effects model analysis depending on the presence of heterogeneity. Trial sequential analysis was also done. The primary outcome of the meta-analysis was sensory and motor block onset time and number of patients having complete block at 30 minutes. The secondary outcomes were the block performance time, the number of attempts and redirections, the duration of block, and any incidence of complications. The 6 RCTs were included for qualitative analysis, whereas 5 RCTs were included for the quantitative analysis. This is the table showing the characteristics of the 5 studies included for the quantitative analysis. Total number of participants included were 374, with 185 participants in the classical group and 189 in the costoclavicular group. The risk of bias assessment was done There was an unclear risk of selection bias in one study because the allocation concealment was not mentioned. There was high risk of performance bias in 3 studies with problems because of blinding of participants and personnel, unclear attrition bias risk in one study, and unclear reporting bias in another study. Now coming to the forest plots for the primary outcomes. When the two groups were compared for the sensory block onset time and 3 studies were included, there was no difference in the sensory block onset time between the two groups with a p-value of 0.53. For the motor block onset time, 3 studies were included for the analysis with no difference seen between the classical and the costoclavicular approach with a p-value of 0.36. 2 studies, there was a combined sensory motor block onset time was studied, and the onset time was significantly less in the costoclavicular group versus the classic group with a p-value of 0.03. Now, when the complete block was studied at 30 minutes, now sensory block at 30 minutes, there was no difference in both the groups with a p-value of 0.72. Motor block seen at 30 minutes, there was no significant difference between the two groups with a p-value of 0.45. Coming to the block performance time, which was a secondary outcome. Now, looking at the imaging time, 3 studies were included, and there was no difference in both the groups when imaging time was studied with a p-value of 0.28. Now, the needling time, which was the block performance time, was studied with 5 studies, and there was no difference in both the groups with a p-value of 0.82. But when the total block performance time was evaluated using 2 studies, which is the combined imaging and the needling time, the time required was less in the classical group as compared to the costoclavicular group with a p-value of 0.01. Coming to the number of attempts and redirection, needle redirection defined as the number of attempts required to withdraw and redirect the needle without complete withdrawal from the skin was evaluated in 2 studies, and there was no difference in either the number of attempts or redirection required in 2 groups. The number of patients having inadequate surgical anesthesia, which means the patient requiring IV narcotics, GA, rescue blocks, or local anesthetic infiltration by the surgeon, there was no difference in both the groups. The duration of block. The costoclavicular group showed a lower duration of sensory block than classical group in only 1 study. Motor block. The 2 studies assessing duration of motor block did not find any statistically significant difference in the 2 groups. Coming to the complications, 3 studies reported no significant difference in the incidence of paresthesia between the 2 groups. There was no significant difference observed between the 2 groups in the incidence of the vascular puncture, and there was no difference observed between the 2 groups on the incidence of Horner syndrome. The trial sequential analysis revealed that the sample size was 0.65% of the required sample size to achieve 80% power, deeming the study to be underpowered. This meta-analysis, which encompassed 5 studies with 374 patients, revealed no significant disparities in motor and sensory block onset times, complete sensory and motor block achievement at 30 minutes, the block performance time, and complications. The overall level of evidence for the outcomes was low. Their heterogeneity was observed, and this could be explained by varied methods which were used to evaluate the outcomes. Faster sensory block in the costoclavicular group in 2 studies may be attributed to large local anesthetic volumes used in these studies with faster spread in the compact costoclavicular space. There was dose variation in local anesthetics across the studies, which underscores the lack of standardization. Significant discrepancy was noted in administration of the classical approach as two of the studies utilized a single injection technique. This poses a limitation while we evaluate the block performance time, the total dose of local anesthetic used, and assessment of block onset thereafter. There was varied block performance time assessments because this parameters was defined differently across various studies. In the classical approach, there was significantly shorter total performance time, which with encompassing needling and imaging due to increased familiarity and experience with the classical approach as compared to the costoclavicular approach. Further studies are needed to evaluate a consistent approach in defining and measuring the block performance time to warrant its assessment as a primary outcome. Both approaches showed similar safety profiles in both the groups. The limitations of this meta-analysis are a small sample size, heterogeneity in outcomes definitions with low evidence grading, inconsistent follow-up methods, and underutilization of the emerging techniques such as costoclavicular approach is noted due to lack of definitive evidence of superiority. Therefore, comparing the classical approach in patients undergoing upper limb surgery under infraclavicular brachial plexus block, the costoclavicular approach showed no statistically significant difference in block onset times, the block performance time, and complications. However, the evidence for these outcomes is low, and further studies are needed to evaluate the findings of the present meta analysis. Thank you.